worked as a lecturer in D.Y.L. Nair Hospital and D.Y. Patil Hospital, Mumbai. And he's completed his fellowship from College of Critical Care Medicine, Mumbai in April 2019. He did his EDIC in November 2021. He's been into private practice as a consultant anesthesiologist in Gadag since 1994. He has special interests in point of care ultrasound, then critical care and regional anesthesia. He's been an executive member representing South Zone in All India Organization for Regional Anesthesia from 2011 to 2014. He's invited as faculty for national and zonal anesthesiology conferences to deliver lectures on peripheral nerve blocks and to conduct regional anesthesia workshops. He's moved into critical care since 2015, and he has special interests. He's a sportsman and a health freak. He's interested in electronics, like gadgets, and he loves music, and he's a dog lover. Thank you so much.
Hello, Guru Prasad sir, you can
start.
the
Okay. Yeah. Okay. At the outset, I thank Remedy International for giving me this opportunity to present on arterial blood gas analysis, which is one of the very crucial aspect of critical care. Thanks, Raghu, and all from Remedy. So, because this ABG is a big topic, I thought that I can do it in two parts. I will cover oxygenation and ventilation today, and in the part 2, then I'll go for acid-base balance, or else there are almost about 110, 120 slides, which I don't want to rush up, because the postgraduates and the trainees have to understand this concept properly. Okay, so my outline of my talk will be to know the fundamentals of oxygenation and ventilation, the concepts of acid-base handling by buffer-based system, and I'll be mainly going through the Boston approach. That is the whenever they give me the next chance. Okay, part 2. So what is the outline of the presentation? Why should we interpret ABG, and what do we get from the interpretation? What are the important variables you have to know before you interpret an ABG, and how to know the oxygenation status, ventilation status, and the acid-base status. And regarding the acid-base status, I'll skip now. So why do we need to interpret an ABG? So it actually aids in establishing a diagnosis, okay, when based on a patient's history, examination, and additional lab data. Most of the times I have seen people just giving the ABG and asking you to interpret. I think that's not the right way. Only with a correct, good clinical history, and once you examine, and when you are given additional lab data like serum electrolytes, what I have observed is the electrolytes what you get in on an ABG report doesn't match with the true electrolytes. So always when you are handed over an ABG, you should ask for at least a serum electrolyte which has been drawn at the time when the ABG was drawn. Second thing, you have to know the FiO2 at which the ABG was taken, so that you can interpret the oxygenation properly. You should also know the albumin levels, because most of our critically ill patients are hypoalbuminic, and albumin is a weak acid. So severe hypoalbuminemia may come in if you don't know the albumin levels. So your interpretation of ABG may be wrong. Something when you calculate which may look like a normal anion gap metabolic acidosis, when you correct the albumin for its albumin levels, for the normal albumin levels, then an high anion gap may be exposed. So you have to have additional lab data before you interpret an ABG. And definitely, at least you can make few valid differential diagnoses with the help of an ABG. So again, once you interpreted the ABG, how does it help? It helps in your guiding of a treatment plan, and also how exactly whether the ventilator setting on which the patient is on is right or wrong. So that you come to know. So many times the patient presents with severe tachypnea. You put the patient on ventilator, After 1 or 2 hours, when you get an ABG, you see respiratory acidosis. That's because the patient was tachypneic. He was breathing at 40, 45, or 50 times a minute. Then you put the because he was trying, he was tachypneic to compensate for his metabolic acidosis. Then you put the patient on ventilator, parents put the patient on ventilator, and you happily put the respiratory rate as 18 to 20. So when you see the ABG after 2 hours, there is respiratory acidosis. So the ideal way is, when you put the patient on ventilator, try to match the respiratory rate at which the patient had presented, so that you get a proper ventilation for the patient. Next, what is the problem if the patient is not treated? What if the patient's ABG, the acid base status doesn't improve? In an acidic environment, and none of these medications work to their optimum. So you should try to get the acid base status to near normal, if not normal, so that whatever medications you are giving should act, including the vasopressors. And also the electrolytes will be very much derailed. For example, if a patient is in severe metabolic acidosis, the hydrogen ions, which are very high in the blood, they tend to go intracellularly. Once they go intracellularly, to maintain the homeostasis, intracellular potassium comes out. So there will be hyperkalemia. So these things you have to keep in mind, and this is what you will get through an interpretation of ABG. So what is the main thing you will look at? One is the oxygenation status. So there are few parameters for how to know an oxygenation status. Then a ventilator status is very simple. You have to see the PaCO2 and the acid base status. Okay. So before we start interpreting, we should know the normal values. So the normal pH is between 7.35 to 7.45. The PaO2 is 70 to 100. Okay, this is on room air. So that always you have to mention. Then the PCO2 is between 35 to 45. The bicarb is millimeters of mercury. The bicarb is 22 to 26 milliequivalents per liter, and the oxygen saturation is 93 to 98. But when it comes to calculation, the pH, normal pH what you take is 7.4. Any pH above 7.4 is alkalosis, and below 7.4 is acidosis. Then 40 millimeters of mercury is the PCO2 level when you go for calculation. Anything less than 40 is respiratory alkalosis, and more than 40 is respiratory acidosis. Similarly, for bicarb, for calculation purpose, 24 is a bicarb level. Anything less than 24 will be metabolic acidosis, and more than 24 will be metabolic alkalosis. So how does an ABG look like? It is a piece of paper where nowadays good machines will interpret in a very good way. And what you look at is the pH, then the PCO2. So whenever it is given in kilopascals, you have to multiply it by 7.6. So that is the conversion factor, but that you can set it in our machine, whether you want kilopascals or millimeter of mercury. Then you get a PO2, then the bicarb. Okay, I personally would advise you not to take any of these values, and you have to get separate serum electrolytes. Okay. Then if it is an co-oximeter, you will get carboxyhemoglobin, oxyhemoglobin, methemoglobin rather, and you also get the oxygen saturation. So all these are very important, especially if you are looking at carbon monoxide poisoning or methemoglobinemia. That time, if the PaO2, the saturations on, you have to look at the saturations on an ABG, SaO2, and the PaO2 and the SpO2. If there is a gap, then you know that there is some saturation gap. So these values also help you to come to a diagnosis. And you can get these values of various values of carboxyhemoglobin, oxyhemoglobin, and methemoglobin only if you use a co-oximeter. So as I said, these are the values which are looked at. So I did tell you during the introduction, what are the prerequisites? You have to get a proper history and clinical scenario. You should know the FiO2 because you should know a PaO2, if it is 90, you may think it is normal. But if the patient is on 100% oxygen, FiO2, and the thing is, and the PaO2 is 90, that's not a good sign. This patient's lungs are bad. So you have to know the FiO2 before you interpret the oxygen status of the ABG, in an ABG. And similarly, you should know the serum electrolytes, which I already highlighted, and the serum albumin. So because if the patient is hypoalbuminemic, you should correct the albumin to get the proper acidosis. Now, where do the acids come from? In an healthy individual, they are actually obligatory intermediates of carbohydrate, fat, and protein metabolism. Also, the cationic amino acids and sulfur containing amino acids, they also produce acids. But what is more important is in a diseased individual. So where does the acid come in a diseased individual? For that, we always see if the patient is there is a metabolic acidosis. In a high anion gap metabolic acidosis, we have what a mnemonic called as mud piles. So M stands for methanol, U stands for uremia, D stands for ketoacidosis. It can be diabetic, starvation, or alcoholic ketoacidosis. P stands for paraldehyde, paracetamol. I stands for INH or iron toxicity. L is lactic acidosis. E is ethanol, and S is salicylate. So you have to know this. You should know why the acidosis is there, and mud piles is a good mnemonic. Then if it is a normal anion gap, then you have to see whether it was because of an GI loss of bicarb, or whether it was GI or renal loss of bicarb, or it was because of an iatrogenic cause like hyperchloremic metabolic acidosis. That they are the few causes of NAGMA, which will be taken in the next class. So what are buffers? Buffers are basically solutions which are combination of two or more chemical compounds which combine with a strong acid and or a strong base to make them weak acids or weak base. Okay, and what is the main thing? The Henderson-Hasselbalch equation helps you to calculate the pH of a buffer solution. This is what the new machines do. So what does the Henderson-Hasselbalch equation say? The pH is equal to the acid dissociation constant plus the log of the conjugate base divided by the weak acid. So A is the conjugate base, HA is the weak acid, and K is the acid dissociation constant. So apart from, so next what you have to see is why the pH, why does the patient has a particular pH? That is because of the acid dissociation constant. So basically there are two types of buffers. They are called as a bicarbonate buffers or a non-bicarbonate buffers. So bicarbonate buffers are the main buffers which are, but unfortunately they have got a low dissociation constant, that is 6.1. They are nowhere near the normal pH of 7.4. But why I say it is a major buffer is because they are found in large quantities, unlike the non-bicarbonate buffers. And it also is an open-ended buffer system. When the bicarbonate is used, it is an open-ended buffer system, which I mean to say is it can alter the pH either via the lungs or the kidneys by affecting the carbon dioxide levels or the bicarb levels. So this is the basic reaction, which can either go in either direction. Either the carbonic acid can split to form water and carbon dioxide, or it can split to form generate an hydrogen ion and a bicarbonate. So it is an open-ended buffer system. So the carbonic acid production and elimination is directly proportional to the partial pressure of carbon dioxide. So they are interrelated. And when you replace the weak acid and the base with bicarbonate and carbon dioxide, what you get is a simplified Hasselbalch equation. That is hydrogen ion is equal to 24 into the PaCO2 divided by bicarbonate. So all these values you get in an ABG. So this will help you to know the validity of the ABG. Okay. Whenever the value what you get here will tell you how much of hydrogen ion concentration is there in the blood. And if that can match the pH, then you can say that the validity is good, because there is no point in solving an invalid ABG. Fortunately, the newer machines, they are not the ABGs what are handed over to you are not valid, are not invalid. Most of the times it is valid ABGs. Coming to the non-bicarbonate buffers. So in the intracellular fluid, you can find proteins and phosphates, which are the other buffers. So what we saw initially was a bicarbonate buffer. This is the non-bicarbonate buffer. The main protein buffer you can find in the hemoglobin, that is in the RBCs. That globin forms the main predominant buffer. And the secondly is the phosphates. Phosphate buffer are also very effective. They are effective compared to the carbonate because the acid dissociation constant almost matches with the pH of the blood. So phosphate buffers and globulin protein buffers are much better. Unfortunately, the quantity of the phosphate buffer is very less, unlike the bicarbonate. So all non-bicarbonate buffers are closed systems, as the end products remain in the system even after buffering, unlike the bicarbonate, which gets either excreted through the renal system or through the GI system. Nevertheless, non-bicarbonate buffers are important as they buffer both carbonic and non-carbonic acids. Coming to the alveolar ventilation, that is the one which controls the carbon dioxide. So as majority of carbon dioxide excretion is through the lungs by alveolar ventilation, it has the greatest impact over the acid-base balance. So the compensation, respiratory compensation happens very fast, unlike the bicarbonate compensation, which takes some time to happen. So how do you calculate? What is the equation for calculation of PaCO2? It is nothing but the carbon dioxide that is produced and the carbon dioxide that is excreted through a proper alveolar ventilation. So if the PaCO2 is greater than 45, that means that the patient is hypoventilating and the carbon dioxide is not put outside the lungs. And if the carbon dioxide is PaCO2 is less than 35, then the patient is hyperventilating and the patient is getting respiratory alkalotic. So these are different causes of hyperventilation, which I will not go through in detail. Anyhow, what you have to know is it can be hypoventilation will cause the carbon dioxide to be retained, and that will form the main part of the alveoli, or because of the muscular weakness, a lot of carbon dioxide is retained. So there can be a central cause for the hypoventilation, or the peripheral cause like the neuromuscular weakness, or the FiO2 only at when you go to higher levels, when the air becomes thin, the FiO2 itself will drop. Actually, the FiO2 is 21%, but because the barometric pressure drops, proportionately the FiO2 also drops. So these are the other causes of which can cause hypoventilation. Chest, post-op, if there is abdominal splinting, or if there is an flail chest, multiple rib injuries can cause hypoventilation. So a few definitions. What is acidemia? Acidemia is nothing but the pH of the arterial pH. It is the pH of the blood. If it is less than 7.35, you call it as acidemia. And if it is more than 7.45, it called as alkalemia. Now, what is acidosis? The process, the process that tends to a lower extracellular fluid pH. That means when the hydrogen ion concentration increases, that is called as acidosis. Acidosis is a process, whereas acidemia is the blood hydrogen levels. Similarly, alkalosis is a process that leads to raised in extracellular fluid pH. As I said, for calculation purpose, pH is 7.4. The normal pH is 7.4. PCO2 is 40. Bicarb is 24, and the anion gap is 12. And how do you calculate, how do you interpret an ABG? It is first you have to check the validity, which I'll tell you how you have to do. Next, you have to see the oxygenation status, the ventilation status, and next, the fourth is the acid-base status. Okay, so these are the main thing. And acid-base status, again, by 6 or 7 steps, you can come to know what is the acid-base status. Coming to checking the validity of the ABG. So this is a table where is one column is pH and the other column is hydrogen ion concentration. So at a pH of 7.4, the hydrogen ion concentration is 40 nanomoles per liter. Okay, and if you see this one, these two, at 7 pH it is 100, and at 7.7 pH it is 20. So there is something called as a rule of 8, which I'll explain to you shortly. For every 0.3 change in pH, the hydrogen ion concentration either doubles or halves. For example, at this pH of 7.4, the hydrogen ion concentration is 40. So for every 0.3 change in pH, that is 0.3, 0.1, 0.2, 0.3, for every 3 change, the hydrogen ion concentration either doubles in acidosis or halves in alkalosis. Do you get me? For every 0.3 change, 7.4, 0.3, 0.2, 0.1. So for 7 pH, you will get a hydrogen ion concentration of 100. Similarly, if you go in the opposite direction, 0.3, 0.1, 0.2, 0.3. So it is double. In alkalosis, it halves. In acidosis, it is double. Okay, sorry. Here I made a mistake. Okay, you have to take this value. Okay, this value and this value. So if for 7.4 pH, if the 40 is the hydrogen ion concentration, for every 0.3, 0.1, 0.2, 0.3, the hydrogen ions double. This is 79, so 40, actually approximately 80. Similarly, if the in alkalosis, for every 0.3 change, 0.1, 0.2, 0.3, it halves. Okay, so what is the rule of 80? Rule of 80 says that for 7.4 pH, the hydrogen ion concentration is 40. For 7.5, it will be 30, and 7.30, it will be 50. So this is the rule of 80. Last two digits plus 50 is 80. Last two digits is 80, and last two digits 50 plus 30 is 80. Okay. So this is how you have to know. If you know these three values, you keep on adding 0.3 and half and double the to know the hydrogen ion concentration. So why is this important? Why should you know the hydrogen ion concentration? Because for a particular hydrogen ion concentration, the pH is matching. So when you calculate using this formula, that is hydrogen ion concentration is 24 into, I told the simplified Hasselbalch equation. It is derived from the main Anderson-Hasselbalch, which I showed you in the previous slide. So how do you calculate the hydrogen ion concentration is 24 into PaCO2 and bicarb. All these values are given in your ABG, and you will get a value that is the hydrogen ion concentration. Once you get the hydrogen ion concentration, you have to match it with the pH given in the ABG. And if they are same, then you say that the ABG is valid. So next, coming to the oxygenation status. So in oxygenation status, you have got 4 steps to do. One is you should know the PaO2. Second is you should know what is the expected PaO2, then the AA gradient, and then the PF ratio. So if the PaO2 is between 60 and 80, then it is hypoxemia. Okay, the process is the hypoxia, but if the PaO2 is 60 to 80 millimeters of mercury, then it is mild hypoxemia. If it is between 40 to 60, it is moderate hypoxemia, and if it is less than 40, it is severe hypoxemia. So looking at the PaO2, you should tell whether the thing is mild hypoxemia, moderate hypoxemia, or severe hypoxemia. Then you should know what should be the expected PaCO2 for a given FiO2. So all of us know that for 21% FiO2, that is room air, the PaO2 is between 80 and 100. Okay, actually maximum is 105. So if somebody tells that the FiO2 was 50%, so how much PaO2 you should expect? 50 into 5 times the FiO2, that should be 250. Okay, if you get a PaO2 of 300, when they say the FiO2 was 50 and you get a PaO2 of 300, that means that the person who has given the sample to the lab has either not heard properly what exactly was the PaO2 when they had given it in the ward. So the PaO2, informing the FiO2 is very, very important to know if you want to know the expected PaO2. Okay, it is 5 times the FiO2. Hope all of you are. The next is calculating the A gradient. Okay, so what is the formula for A gradient? It is nothing but alveolar and alveolar arterial oxygen gradient. So I will try to show you here. So A gradient is nothing but P big AO2 minus P small AO2. Okay, that is a gradient. Why is it important? If the PaO2 is normal, that is, if it is less than 20, then the problem, there is no lung pathology. There is other cause for hypoxia. And if it is more than 20, then there is a lung pathology. Okay. So that is the reason why you have to do an A gradient. The A gradient is done to know whether the cause of hypoxia is because of a lung pathology or for a central cause. Okay, so this is a gradient. So what is the formula? This value is given in the ABG. Okay, this value is given in the ABG. So you have to calculate the alveolar oxygen. So how do you calculate? So the formula is barometric pressure, okay, minus water vapor pressure into FiO2. Okay, so this is one component of the alveolar graph minus PaO2 divided by the respiratory quotient. Now, at room air and at sea level, okay, what will be the PaO2? That's what we have to calculate. So the alveolar oxygen will be, barometric pressure is 760 minus water vapor pressure is 47 into FiO2 is 0.21, okay, minus PaCO2 divided by respiratory quotient is 0.8. Okay, so if it is room air, this value will come to 149, the first part. And if the PaO2 is normal, that is 40 divided by 0.8. So dividing this will be a little bit complicated. So what I will do is I'll show you something, how you have to calculate that second part. What I showed is PaCO2 divided by respiratory quotient, isn't it? So, and I told that PaCO2 divided by 0.8 is the respiratory quotient. Now, divide means when you want to calculate, especially the exams, it is very difficult to do that. So what you have to do is PaCO2 So 0.8 divided by 0.8. What is 0.8? What is, so it is 1 divided by 0.8. Okay. So this will become PaCO2. If you multiply on 10 by either side, it is 10 by 8, which is 5 by 4, which is 1.25. So coming to this equation, so this part actually becomes PaCO2 into 1.25. Hope you have understood this. Okay. So taking this into example, so 149 going ahead, then 40 divided by 0.8 will be 40 into 1.25. Okay, which will be equal to 40 into 1.25 will be 50. Okay, so what value we had got here? 149. Okay, so it is 149 minus 50. So this is 100. This value is 100. And you have to minus this PaO2 by the small PaO2 what is given. Okay. So I'll go back to the this one. So this was the formula for calculating the AA gradient. We will do few examples later on. Okay. Prashant, I think they are understanding what I'm telling, na?
Yes, sir. Yes, sir.
Okay. Raghu, you are also there. Okay. I am trying to prepare them even for the exams at the same time. Okay. So next is the calculation of the PF ratio. So that will help you to know if the especially in ARDS to know the status of oxygenation. If the PF ratio is greater than 400, then it is normal. Okay, which is equivalent to a saturation of greater than 80% on room air. If the PF ratio is less than 400, then there is mild hypoxia. If it is actually the calculation is like this, 200 to 300 is mild hypoxia, 100 to 200 is moderate hypoxia, and less than 100 is severe hypoxia. So you have to calculate the PF ratio. So you will be getting the PO2 in an ABG, FiO2 will be given. So this will also help you to know the oxygenation status. We will do few examples. Okay. So this is an 56-year-old man with a history of coronary artery disease, hypertension, and is a chronic smoker. He has presented with productive cough and dyspnea for 3 days. On examination, his respiratory rate is 28 and saturation is 81% on room air. Okay, so these are the variables what you have been given. Room air is 21%. Okay, that is a value. We will not bother about the acid-base status now. We will look at only the oxygenation status. So what was the first step I told? You should know whether it is a mild, moderate, or severe hypoxemia. So it comes in moderate hypoxemia. 60 to 80 is mild hypoxemia. 40 to 60 is moderate hypoxemia, and less than 40 is severe hypoxemia. So this is moderate hypoxemia. Okay. Next is the expected PaO2. For a FiO2 of 21, the expected PaO2 was 105. So here also it is less. That is accepted. Why you want to know is if it is more. Next is the AA gradient. So I will try to calculate the AA gradient for you. 60, 52. Okay. So what is FiO2 is 21%. Then PCO2 was 60 and PaO2 is 57, isn't it? So now you have to do an A gradient to know whether the problem is with the lung or not with the lung. So first we will calculate using these two parameters the alveolar big AO2. So that will be 760 minus 47 into 0.21 minus PaO2 is 60 into 1.25. Okay, so you will get the first part of the equation here. So as I said, because on room air this will be 149, you can take it to 150. Okay, so 60 to 1.25 is, so I'll try to tell what is 1.25. 16 to 1.25, 60. 1.25 is nothing but 1 plus 0.25. Hope all of you agree that 1.25 is 1 plus 0.25. So one part is 60. So then you have to get the 1/4 of this. Okay, so 1/4 of 60 is 15. So it will be 75. So 60 into 1.25 will be 75. So you will not have to have any calculator. So this value will be 75. The PaO2 given is 57. Okay, so it will be 18. So the A gradient here is 18, which is probably because this patient is a COPD patient. He is hypoventilating and his carbon dioxide is filling the alveoli, and that is the cause for his hypoxia. So you got it. This is how A gradient helps you to know whether the hypoxia is because of the lung pathology or not because of the lung. So here you got an A gradient of 18. That means that this is a COPD patient who is a chronic PaCO2 retainer, carbon dioxide retainer, and the problem is because of carbon dioxide retention. So here the lung pathology is okay. And probably what productive sputum is getting is because of the bronchitis or tracheitis, whatever it is. So next we'll go to sample ABG2. So this is an 83-year-old female found to have fever and shallow breathing at home. Okay, fever, shallow breathing at home. Was brought to the ER. On arrival, she is in distress. She is having fever, tachycardic. BP is almost normal, but is tachypneic, and the saturation is 75% on room air. So what does the ABG show? On room air, the pH is, so we'll not bother about this now. The PCO2 is 26 and the PaO2 is 41. So what are the 4 steps you look at? First, you have to see what is the degree of hypoxemia. Because it is 41, less than 40 is severe. It is 41, you can call it as moderate hypoxemia. Okay. Next, what should be the expected PCO2, expected PaO2 for this one? Because again, it is room air. You should expect 105. That is also okay. Next, you have to calculate the A gradient. So A gradient, I'll just show you how we will calculate here. So what are the room air is one variable you should know. Second is the PCO2 is 26 and PaO2 is 41. Okay, I think I'm right. Okay, yeah. So how do we calculate the A gradient? Big A minus small a. So how do you calculate this? So room air, because it is room air, your first value will be 150. Next is you have to calculate PCO2 into respiratory quotient, that is 1.25. So here I taught you that mathematics. What you have to do is you have to take 4 parts of it. So it will be around 6. Okay. So 26 plus 6 will be 32. So this value will be 32. So 150 minus 32 will be 118. Okay. The part 1 is 118. minus the PaO2 is 41. Okay, 7 and 7. So 77 is the AA gradient. That means that this patient has having some lung pathology. Okay, so this is how you calculate the AA gradient. 118. It came to 100. Sorry, 118. Yeah, 7 and this. Sorry, 11 minus 4 is 7. Yeah, so 77 is the AA gradient. Okay, that is 71. So next is as the age progresses, the AA gradient also increases, keeps on increasing. So what is the formula for that? The formula for that is age divided by 4 plus 4 is the formula to know the approximate AA gradient as the age goes by. For example, if the age of the patient is 80 years, age divided by 4 plus 4, that will be 20 plus 4. So 24 is a normal AA gradient for an 80-year-old man. So that also you will come to know. So what are the etiologies of hypoxemia? And again, the fourth step would have been calculating the PF ratio. Again, PF ratio, PaO2 is 41. Then this is 0.21. Okay, so it's almost you can because it is roommate, you can tell it as it is a moderate hypoxemia. The PF ratio will be around 100 to 200. Okay, so that is how you calculate the PF ratio. Now, what are the etiologies of hypoxemia? If you look at this chart, either it can be because of a shunt, either or because of a mismatch, or because of impaired diffusion. So interstitial lung disease is one of the major cause because the lung parenchyma is distorted. Whereas leaky miscarriage can be seen in COPD. There is an overlap. And interstitial lung disease, you can find all three types of causes for hypoxemia. COPD also the same. Whereas if it is a right to left intracardiac shunt, it is mainly the shunt which causes a problem. If it is a pulmonary embolism, it can be mismatch as well as partial shunt or partial effusion, impaired diffusion. So these are the etiologies of hypoxemia. Now, how do you approach hypoxemia? What you do is you calculate the AA gradient. If the AA gradient comes as normal, so the cause may be hypoventilation or low atmospheric pressure. That is what you see in high altitude people. Next is if the AA gradient comes high, then there is a lung pathology. You give oxygen, 100% oxygen. If the PaO2 or SpO2 doesn't increase, then the cause for hypoxemia is shunt. Okay, and if it improves, then the cause may be because of VQ mismatch or impaired diffusion. Okay, so this is how you calculate the do the first step in ABG, that is the oxygenation. Next, coming to the ventilation status, it is very simple. What you have to see is you have to look at the PCO2 levels. The normal is 35 to 45, or though for calculation purpose it is 40. If the PCO2 is greater than 40, that is there is respiratory acidosis, and you call it as, and the cause is hypoventilation. Okay, and if the PCO2 is less than 40, that is respiratory alkalosis, and it is hyperventilation. So ventilation status is very easy to know. I think with this I will end my presentation. And one more thing, what you have to know is the change in pH in acute and respiratory acidosis, alkalosis can be acute or chronic. So in an acute respiratory alkalosis or acidosis, for every 10 change in PCO2, the pH changes by 0.08. Okay, whereas in chronic, for every 10 change in PCO2, the pH changes by 0.03. Just I'll try to give you an example. So if the PCO2 is 60, okay, and you think this is an acute cause, so the normal pH is 7.4. So this has increased by 20. So for every 10 what we told, it will affect the pH by 0.08. So one 10 is 0.08, the second 10 is 0.08. So it is 0.16. So you have to minus 0.16. Okay. So it will be 7.24. So if the process is acute, the pH will be 7.24. So just by looking at the pH also, you will come to know whether the PCO2 is acute or chronic. But same PCO2, if it is in a COPD patient, okay, the calculation will be different. So again, the PCO2 is 60. The change in pH, what you are expecting is 0.02. So from 40 to 50 is 0.03. Okay, and from 50 to 60 is another 0.03. So 0.06, and the pH, expected pH should be minus 0.06, that is 7.34. So in a chronic COPD patient, if there is a PCO2 of 60, you mean this is actually the pH would have not moved too much because it's a chronic retainer. So just by looking at the pH and the PCO2 levels, you can make out whether the cause is acute or chronic cause. Okay. Similarly, if it is an alkalosis, if the PCO2 is 20, okay, so it has changed by 20. Normal is 40, so it is changed by 20. So if it is an acute respiratory alkalosis, again, now here you have to subtract it. Okay. Sorry, you have to add because it is alkalosis. Okay. So you have to add 0.16 because it has changed by 20, 0.08 and 0.08. So it is 0.16. So if it was an acute respiratory alkalosis, the pH would have been 7.56. But if it is an chronic respiratory alkalosis, then the change will be only 0.06. So it will be 7.46. So this is how you can make out whether the the change in the CO2 accumulation or washout is because of an acute process or a chronic process. Thank you.
Without support for the background.
Hello.
Raghu.
Sir,
Yeah, I'm there.
excellent presentation, sir. You're becoming master in explaining ABG. Dr. Reshma?
Thank
Yeah.
No,
Okay.
over the years, by doing this, I want to teach the trainees how to calculate the ABG without calculator.
Yeah, that's what I was observing, sir. Like a
Yeah.
1.25, how to make it, that part. Easily we can
Yeah.
calculate
Yeah.
without any calculator or even.
Yeah, you have to just the PSO2 value, you have to just divide it by 1/4 and add to it.
Okay. Dr. Reshma, Dr. Prashant,
You are muted, Reshma.
okay.
Yeah.
Yeah.
It is Reshma muted. You are muted.
No, sir.
No, she's now she's okay. Now she's okay.
Okay.
Yeah, we can hear you.
Sir, to make it simple, like that half and double
Of what?
with every like 0.3 change, there is it gets doubled to the acidotic side, right?
You are talking about respiratory acidosis or something else? Acha, you are
Acidosis.
talking about the hydrogen ion concentration. You are talking about the hydrogen ion concentration, isn't it? So if the this one the hydrogen ion concentration, see for 7.4 pH, Okay, it is 40. That much we know. Okay,
Yeah.
for 7.3 pH, it is 50. Rule of 80. 30 plus 50 is 80. 7.40 plus 40 is 80. 7.50 plus 30. Okay. Okay.
Double.
Yeah. If it is acidosis, the hydrogen will double. If it is
Okay.
alkalosis, it will halve. It will halve. So if the pH is 7.40,
Yes, sir.
okay, for 7.1, okay, that is 0.3, 0.2, 0.1. For 7.1, it will be double of 40. That is 80.
Yeah. Yes. When it comes to 7.2, like 8, then it is 20.
Yeah. No, if you
Okay.
want to, I can explain you again. Okay. Can you see the screen now?
No, sir, not
You
yet.
can see?
Not,
Okay.
not
Okay.
yet, sir.
Okay. Okay. I'll try to. What I have to do is okay.
Uh-huh.
Can you see now? Can you see the screen now?
Yes, sir. Yes, sir.
Okay. 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 So what I will do is, we will take this table. Okay. 7.40 plus 40 is equal to 80. 7.30 plus 50 is equal to 80. Okay, 7.50 plus 30 is equal to 80. Okay, so now for every 0.3 change, if at all, what I'll do is I'll just drop this. So we know here it is 30, here it is 40, and here it is 50, isn't it? So we'll take here for every 0.3 change. Now this is 40. If it is 0.1, 0.2, 0.3, 7.1 will be 80. Okay.
Yes, sir. Yes, sir.
Okay.
Yes,
On the
sir.
other side, if you want to go on the alcolytic side, 0.1, 0.2, 0.3. So 7.7, it will be half. Okay. This is exactly the table what I showed you before. Isn't it?
Yes, sir.
See, now 7.1 came as 80. It is around 79. Okay. And 7.7 came as 20 only. So here you can see 0.1, 0.2, 0.3. It from 40 it has doubled to 80. From here 0.1, 0.2, 0.3. From 40 it has held to 20. Okay? Convinced?
Yes, sir. Yes, sir.
Okay. Yeah.
If there is no more questions, can you conclude, sir? I think when you are going to take next one,
Yeah,
sir?
yeah. Whenever you say. No, because this only took almost about 45 minutes. I didn't want to bore them, isn't it?
Yes, sir. Yes, sir.
Because acid base again is a big, means there are a lot of steps in that, a
Mm.
lot of calculations. So I didn't want to make them more burdened about it. But whatever I am telling, it's clear, na?
Yes,
Yes,
sir.
sir.
It's not.
Yes, sir.
It's not confusing. Yeah, yeah. Okay.
There was good attendance. More than 23 students attended today.
Acha, acha. Good, good.
They're
good,
all of,
good.
fond of your ABC class.
I think I had shared it with some of the postgraduates in Gadag also.
Okay.
Gadag Institute of Medical Science and another CSI hospital. They would have also joined actually. I don't know.
Mhm.
No, actually, COVID has made to learn us all these things. Or else where we knew about Zoom and all.
Correct, correct, sir.
No, if I did my fellowship before COVID, then I would have sat here and taken attend your classes, Raghu. Good, it came after that. I could meet people like Prashant, Raghu, Lakshmikant. We used to enjoy. That 1
Yes,
week
sir.
was enjoyment but for me. Work and enjoyment. Anything else? Let me know.
Yes, sir. Reshma,
The students can't ask questions here.
they can only chat, put the questions in the chat box actually. Only it is a
Students,
parallel to the
Yeah,
chat
they
box,
can
sir.
hand.
I think Shravya can unmute them if they have got asked. But nobody in the chat box also, nobody is there. Yeah.
Students, if you have any doubt, you can raise your hand.
What do we do, Shravya?
So I think like everyone is clear. So
Okay, okay. Great, great. For us,
yeah,
it took years to understand. No, for us, it took years to understand ABG.
yeah, like I can take up the
Can we
second part.
Yeah. Okay, we can leave the meeting.
Yes, sir, yeah.
Raghu?
Yes, sir. Thank you so much, sir, for your
No,
presence.
for all in this platform, I proudly say that I'm a student of Raghunath.
Yeah.
I
And in
proudly
spite
say
your
that.
busy schedule, you left your OT and came here. Thank you so much.
No.
In spite
Yeah,
of busy schedule, you are here.
Yeah, next time I'll plan properly. I'll not commit to
No,
anybody.
no. And Reshma,
Okay.
Yeah, thank you so much,
if you
sir.
want to
Thank you, sir.
conclude, yeah,
Yeah,
please.
Yeah.
Okay.
Okay.
It was a very
Thank-
clear presentation. I've been here into multiple classes, but this was the best, I suppose.
Thank you.
Thank you so much,
Thanks a
sir.
lot.
Yeah.
Okay.
And
Thank you. Thanks a
last
lot.
session day, sir. I think in last FCI, hello,
Hello.
sir. Am I audible?
Yeah, I can hear you, Raghu. Prashant.
In last we conducted the program, sir. Your class was many people liked your classes
Workshop.
workshop. What we did in
Acha. Acha, in the South Zone conference.
South Zone, yeah, it was a part of the South Zone conference. So
Correct.
in that, your class was appreciated.
Okay. Yeah. Thank you.
More clear the concepts, better people appreciate it.
Yeah. Okay.
Thank you, sir.
Okay.
It was very nice.
Yeah. Thank you. Thank you
Thank
then. Okay. Bye.
Thank you all. Thank you so much.
Yeah.
Bye.
Bye, Raghu. Bye.
Bye, sir. Bye.